Diagnosing infective endocarditis in patients with prosthetic valves or intracardiac devices is a distinct clinical challenge. Metallic and synthetic hardware create dense acoustic shadows and reverberation artifacts that often obscure the very lesions doctors need to see on a standard echocardiogram. Because the modified Duke criteria rely heavily on clear echocardiographic evidence, these hardware artifacts often prevent a definitive diagnosis. Without a clear view of the valve, the criteria cannot confirm or rule out the presence of infection. This flowchart tracks 92 stable patients with suspected IE. When using only the modified Duke criteria, over half of these patients, 54%, could not be definitively diagnosed, leaving them in the indeterminate possible category. Relying on these traditional criteria alone results in a high rate of uncertainty. Every day a patient remains in the possible category is a day that critical medical or surgical management is potentially delayed. This diagram shows IE case reclassification. Combining metabolic activity with anatomy resolves indeterminate cases. The orange row tracks 50 possible IE patients. With PET CT, that group drops from 54 to 5%. They are reclassified as definitive or rejected, raising diagnostic sensitivity to 90.7%. Molecular imaging provides a shift in the diagnostic endpoint, replacing clinical guesswork with anatomical and metabolic confirmation. Obtaining these results requires a strict preparation protocol. To prevent the heart muscle from consuming the glucose tracer, patients fast for 12 hours and receive intravenous heparin 15 minutes before the injection. This ensures that the myocardium is metabolically quiet, allowing only the infected areas to glow on the scan. These ROC curves establish the exact metabolic thresholds to identify infection. For screening, an SUV max of 3.7 or an SUV ratio of 1.69 identifies positive cases with 91% sensitivity. To confirm infection with 100% specificity, thresholds are higher, SUV max 6.87 or ratio 3.45. For prosthetic valves, these quantitative metrics provide the objective data needed to rule in an active infection. Fused PET CT scans reveal periaortic soft tissue components on the workstation. This scan shows an SUV max of 12.69, confirming a Staphylococcus aureus infection. It localizes the exact boundaries of the periaortic abscess, providing surgeons with a clear map of tissue destruction. This pattern of focal and heterogeneous activity in the valve rings is consistent across different prosthetic types, including the aortic and mitral valves shown here. Focal hypermetabolism aligning perfectly with the valve hardware strongly indicates an active infection. However, these numerical SUV thresholds are unreliable for intracardiac devices like pacemakers or defibrillators. Because device leads have a baseline metabolic signal very similar to the surrounding blood, a simple quantitative ratio often leads to a false negative. Instead, device reads rely on qualitative visual analysis. Specialists look for focal uptake in specific locations, like the generator pocket in panel A, or along the intracardiac leads in panel B. To improve visualization of these leads, the protocol can be adjusted to a 3-hour delayed acquisition, which allows the background blood signal to fade. Device evaluations require this type of pattern recognition rather than a reliance on automated numerical thresholds. These stacked bar charts compare the results of standard non-enhanced PET CT against contrast-enhanced ECG-gated CTA. When CTA is added to the study, the rate of indeterminate possible cases falls from 20% to just 8%. This improvement is possible because the anatomical detail of CTA can detect periannular complications, like fistulas and small abscesses, that standard CT scans miss. Adding IV contrast and ECG gating to the workflow represents a significant increase in diagnostic clarity over the standard PET CT scan. We see the impact in these direct anatomical comparisons. In panel A, the CTA clearly shows a periaortic abscess causing coronary compression, missing in standard CT. Panel B highlights ECG gating. It prevents motion smearing and correctly identifies a non-infectious postoperative pseudoaneurysm, avoiding a false positive. This level of detail helps distinguish true pathological infection from postoperative changes, preventing unnecessary surgical intervention. Despite its high sensitivity, the modality has limitations. PET CT can miss vegetations that are smaller than its spatial resolution, and its sensitivity decreases if the patient has been on broad-spectrum antibiotics for more than a week. There is also a risk of false positives in the immediate postoperative period. Tissue inflammation or the use of surgical glues like bioglue can create intense metabolic signals that mimic an infection. However, the whole-body scan provides a secondary benefit by mapping systemic involvement. In this patient cohort, whole-body PET-CT identified clinically silent peripheral emboli in 15% of cases. Finding these distal infections provides additional confirmation of the cardiac diagnosis. While clinicians must account for temporal and surgical artifacts, the whole-body scan offers a comprehensive map of both the primary infection and any embolic spread. The diagnostic algorithm for prostatic endocarditis is changing. When standard criteria and echocardiography are inconclusive in high-risk patients, 18F FDG PET-CTA is the definitive next step. A successful study requires strict myocardial suppression and the anatomical precision provided by IV contrast and ECG gating. Interpreting these scans requires a split approach, applying quantitative SUV thresholds for valves, but relying on qualitative pattern recognition for pacemaker and ICD leads. PET-CTA provides the spatial and metabolic clarity needed for a conclusive diagnosis, providing a way forward for patients who would otherwise be left with a possible IE classification.